Hi friends, welcome to Plexus Ortho. My name is Dr. Kannan Kumar. I'm your upper extremity consultant at Plexus Ortho. Today we're going to continue with the second part of the brachial plexus injuries. We're going to discuss about nerve injuries. So here we can see a demonstration of a partially cut nerve. You can see the nice pouting fascicles that are visible in this picture. The surgeon is holding gently with two microforceps and he's going to repair probably fascicular repair or the epineurial repair can be done for this case. So you know the three coverings of the nerve. The outer covering is called the epineurium. The fascicles are covered by what is called as the perineurium, and the axons inside the fascicles are covered by what is called as the endoneurium. So this is very important for classification of nerve injuries. Seddon's classification. Seddon first classified this in 1941. Seddon is the most commonly used classification. There's a second classification which is called as Sunderland. This question will invariably be asked in your theory. So at least 1 out of 4 of your papers will have a question on Seddon's classification, and it will definitely be asked in the practicals and in future life practice as well. It is a very important condition to remember, classification to remember. So Seddon gave 3 classifications. First, he called it neuropraxia, first level. The second grade or the second level is called axonotmesis. Type 3 is neurotmesis. So when the myelin sheath is only injured without disruption of the internal axon, endoneurium, epineurium, or perineurium, then it is called as neuropraxia. It is usually because of a compression or a stretch. So where do we see this compression or a stretch? We see it in carpal tunnel syndrome. We see it in thoracic outlet compression. We see it in Saturday night palsy. We see it in crutch palsy. Wherever there is a compression or a stretching of the nerve, then it is called as a neuropraxia. Here the myelin is damaged or the outer sheath is stretched or compressed. And these are the conditions where neuropraxia is present, and it can usually recover very well. For example, a Saturday night palsy recovers within 3 to 6 weeks. If something does not recover within 6 weeks to 3 months, then it probably is not a neuropraxia or it is a mixed nerve injury. So therefore, again, the carpal tunnel syndrome, once you release the carpal tunnel syndrome, most of the times the nerve recovers its function. So this is called as a neuropraxic injury. Most of your humerus fractures with radial nerve palsy are also neuropraxic injuries. For example, the Halston-Lewis type of humerus fracture, where the distal fragment presses on the lateral intermuscular septum and stretches the radial nerve, is also a neuropraxic injury. The second type of injury is axonotmesis, where the endoneurium is injured. The axon is disrupted, and therefore the axon has to grow back. It has to grow back from the point of injury. Valerian degeneration occurs. We'll discuss Valerian degeneration in a few slides. Valerian degeneration does not occur in neuropraxia, but it does occur in axonotmesis. So therefore, you will have, whenever Valerian degeneration occurs, you will have a positive Tinel sign. Then a progressive positive Tinel sign indicates that the axon is trying to grow back through the disrupted endoneurium. So therefore, this is called as axonotmesis. Axonotmesis is further classified into 3 levels by Sunderland classification, which we'll discuss next. What is neurotmesis? Neurotmesis is a complete disruption of the nerve, and there is no chance of recovery of the nerve without the surgeon's intervention, which is a very important concept. So neurotmesis must and always require a surgeon's intervention to repair the nerve, to bring it back to its continuity. So these can happen in lacerations. They can happen in brachial plexus injuries. These can happen in dislocations. It can happen in trauma. So all these conditions, it is called as neurotmesis. Why neurotmesis should be identified early? It should be identified early so that the surgeon can intervene early and the treatment can be provided at an early stage. So what are the 3 classes or grades that have been classified by Seddon? Neuropraxia, that is, there is a compression or a stretch of the nerve without a discontinuity of the axon. Axonotmesis, that is, there is a discontinuity of the endoneurium or the axon, there is a positive tinal sign, the nerve has to grow back. There may or may not be a surgeon involvement required. So therefore, this is in between the neuropraxia and neurotmesis. Neuropraxia does not require a surgeon or surgical involvement and usually recovers on its own, whereas oxonotmesis requires a surgeon involvement, and a neurotmesis always requires a surgeon involvement. And there will be a non-progressive tinal sign in neurotmesis at the level of the injury, whereas in axonotmesis, the nerve will start to grow back, and you will probably see a progressive tinal sign over a period of time. Now let's go to the second classification, important classification from exam and practical point of view. It is a Sunderland classification. Sunderland type 1 is basically type 1 of sudden neuropraxia. There is local myelin damage, compression, but the nerve is intact. The second, axonotmesis, is further divided into 3 levels. Axonotmesis, the first one is type 2 in Sunderland classification. The continuity of the axons is lost. But the endoneurium, perineurium, and epineurium is intact. So this is axonotmesis type 2. In type 3, you have endoneurial injury, that is, you have discontinuity of the axon. Along with that, you have an endoneurial injury. In type 4, you have a type 2 injury, that is, you have discontinuity of the axon, you have the discontinuity of the endoneurium, along with it, you have a discontinuity of the perineurial injury. But the only thing that is intact is now an epineurium. As I have said, P is after N, and therefore P is the outer layer of the nerve, that is epineurium. Endo is the innermost or the covering of the axon, and perineurium is the middle or the covering of the fascicles. So if you can see very clearly, because the endoneurium is intact, it probably does not require any surgical intervention, and the axon may be able to grow back into the endoneurium. And what is the rate at which it grows back? We say usually about 1 millimeter per day or 1 inch per month is the rate at which the nerve grows back once it is disrupted. In type 2, there is an endoneurial injury. This may also not require a surgical intervention, but type 4, where there is a perineurial injury, most of the times you will require a surgical intervention will be required. Type 5 is the same as type 3 of the Seddon's classification. It is called as type 5 Sunderland classification, where there is a complete transection of the nerve. The tinal sign is non-progressive at the site of injury, and early surgical intervention is required, and prognosis is poor with any kind of nerve injury. So these are the 2 classifications that you should remember. One is Seddon's classification, and the second one is Sunderland's classification. These are the 2 classifications which are important for your exam purposes. Now, what happens when there is a nerve injury? Okay, let us forget about neuropraxic injury. Let's discuss about axonotmesis and neurotmesis. What happens when there is a nerve injury? What happens is called as Wallerian degeneration. Wallerian degeneration occurs when there is a injury to the nerve. So what basically happens in Wallerian degeneration? Let us say this is the nerve cell or cell body of the nerve, and then you have the axon, which is like this. If the nerve is cut here, then the portion distal to the injury is completely emptied of its contents, that the endoneurium is emptied of the axonal contents by macrophage-like cells, macrophage-like cells. Okay, this also happens one node of Ranvier proximally. Wallerian degeneration occurs, which is emptying of the endoneurium or the tube with the axonal components, and this is called as retrograde Wallerian degeneration. The one which occurs distally is called as antegrade Wallerian degeneration. So remember this, at the site of injury, all the components distally is engulfed or it is cleared off by macrophage-like cells. This is called as antegrade Valerian degeneration. One node of Ranvier proximally, the nerve is cleared of its axonal components, and this is called as retrograde Valerian degeneration. How long does this Valerian degeneration take place? It takes place from 14. It takes up to 14 to 21 days from the date of injury. Therefore, the important concept here is that you should not get a nerve conduction study or an EMG study done in this 14 to 21 day period immediately after injury, because then the muscle may still be excitable because the Valerian degeneration has not occurred, and this may cloud our judgment regarding these injuries. So therefore, you should never do a nerve conduction or EMG study in the first 3 weeks after an injury. So once the Valerian degeneration is complete, we are left with a hollow tube. The hollow tube is the one into which the new axon grows from the proximal end of the proximal one step node of Ranvier. The axon again grows back into this hollow tube. So this tube has to be cleared of its contents before the axon can start growing. And the process of clearing this contents in the axon is called as a Valerian degeneration. Now, there are multiple factors which we don't have to remember as orthopedicians, but there are multiple growth factors and stimulants which guide the axon towards the endoneurium and the path of growth. And this portion where it grows is called as a growth cone. So there are multiple fibrillatory processes which try and search for the right direction to grow into the endoneurial tube, and this is called as a growth cone. So multiple Schwann cells, they form multiple layers. Let's say if this is a site of injury, the Schwann cells try and make tubes of myelin through which the nerve starts to grow, and this is called as bands of Bungner. This is named after a person called Bungner. So therefore, the Schwann cells direct the axons and make a tube for the nerves to grow through these. So this is called as bands of Bungner. Now, this is a very important concept that will be asked repeatedly in your exams. What is the clinical time or the critical time of delay for the nerve repair or nerve transfers? Remember, this is the spinal cord. The nerve comes, or a peripheral nerve, or becomes a brachial plexus, becomes a terminal nerve, let's say the median nerve, and supplies the abductor pollicis brevis. Now, if there's an injury here, the nerve starts to, if there is only a neuropraxic or an axonotmesis, the axon starts to grow and grows at the rate of 1 millimeter per day. So that's quite a considerably slow rate, and if it has to reach the hand all the way, it may take a few months to even a few years. So the motor end plate, that is where the nerve connects with the muscle, dies after a period of 12 months. So this is the average you can remember for all the nerves. Different nerves have different critical limit by which you should do nerve surgeries or do some correction to make the end plate active again, motor end plate. So the motor end plate dies or degenerates in 12 months' time. So any nerve surgery has to be done within a period of 12 months to restore function to the muscle. So this is called as the critical limit of delay. It's a very important concept. It's a little different for different nerves. For example, the radial nerve may be from 9 to 12 months. The ulnar nerve has a lesser critical limit of delay, 6 to 9 months. The median nerve is in between these two, and the common peroneal nerve is even lesser. So, but the average date beyond which you cannot do a nerve repair, or you should not do a nerve repair, or the answer in your exam where you should not do a nerve repair is 12 months. Beyond 12 months, don't attempt a nerve repair because the results are going to be poor because the motor end plates have been damaged. Okay, this is different for sensation. Sensory organs do not die or degenerate within a year, and therefore, if your aim is to only restore sensation, you can do it up to 3 to 4 years time. So, for example, if there is a patient who comes with a median nerve injury after 2 years, it's important to get back the sensation of the thumb and the index finger. To get this sensation back, you can restore or do a nerve transfer or a nerve graft or a nerve procedure up to 2 to 3 years to restore the sensation. So sensation is different, remember, but motor critical limit of delay is 12 months. And this is a very important concept in managing these patients.